Thank you for joining us today for our webinar, Assessment of the Newborn with Antenatal Exposure to Drugs. My name is Lee Montville, and I'm the Director of Special Sales and Business Development at Springer Publishing. Today's presenters are Kathy L. Witt, Dean of the Loretto Heights School of Nursing at Regis University in Denver, Colorado, and Carol M. Wallman, coordinator of the Neonatal Nurse Practitioner Program at Regis University in Denver, Colorado. Both Kathy and Carol have been neonatal nurse practitioners for over 30 years and are the editors of the recently published Tappero and Honeyfield's Physical Assessment of the Newborn, 7th edition. Before we get started, I want to mention that this webinar is being recorded, and if you miss any portion of the presentation, you can find the video on www.springerpub.com 5 to 7 business days post-event. If you have any questions during the webinar, please type them into the Q&A box on your Zoom control panel, and I'll bring them up at the end of the presentation. If for any reason you forget to ask a question, there'll be a brief survey sent at the end of the webinar, and you can include your question there. Now, without further ado, we will turn the time over to Carol and Kathy.
Hi, everyone. First, I just want to thank all of you for being here and to thank you for your commitment to caring for newborns. They're such a vulnerable and important population, and I think it draws special people that care for them. So thank you for being here. Thank you for your commitment to newborns. Today, we have the opportunity to talk with you about assessment of the newborn with antenatal exposure to drugs. And we're going to talk both about the physical assessment component, and then we're going to talk about the component of sharing that information with families and within the healthcare team. So the basic principles of physical assessment include multiple aspects. First is really reviewing the history, the perinatal history of the mom, as well as the neonatal history for the baby. So it's a review of the perinatal history. Then we're going to talk about observation, just that key component of looking and taking the time to truly observe the newborn, and then the other basic steps of auscultation and palpation. Reviewing the perinatal history is, like I said, it's very important. Sometimes we say that a good comprehensive review of perinatal history can actually give you almost 90% of your physical exam. So you want to make sure that you take the time to do that review, and also to take the time to make sure that what you are reviewing is accurate information. It's not that third-hand information, like old telephone tag, not passed on and passed on and passed on. But if you can go to that primary source, or at least close to the primary source of the actual prenatal records, to look at that and to talk to the family. Looking at the perinatal history, and then in looking at it through the lens of perinatal substance use disorders, we keep in mind that that's a very complex diagnosis and one that does carry a lot of stigma with it. So we want to be aware of that, and to keep that in mind as we're working with these families and babies. Again, part of the physical assessment, it's the history. It includes multiple steps of the physical exam. And during that progress, we're doing a lot at the same time. We're thinking about the physical exam. We're thinking about the perinatal history and the knowledge that we have from that. We're observing the baby, and we're then moving on to the auscultation and palpation. So it's a complex process, and one that we're thinking through the whole time that we're doing it. So stepping back and recognizing the issue of perinatal substance use disorders, we know that that is a complex issue. We know that it's unfortunately continues to be a significant concern in the United States and actually throughout the world. We follow data on state level as well as a national level. And the National Survey on Drug Use um, and Health that is done by Substance Abuse and Mental Health Services, SAMHSA, they do this survey on a yearly basis, and it's really been fairly consistent where they found that 5 to 8% of pregnant women are using some sort of substance or consuming a substance during pregnancy. The most common, and I say illicit drugs because on a federal level, marijuana is technically still illicit, even though we have seen a significant move towards legalization on the state level. But marijuana is the most commonly consumed drug during pregnancy, followed by opioids, cocaine, alcohol. And then there's also cigarette smoking. And I should say alcohol and cigarette smoking, they, well, they're legal, so they're not necessarily considered the illicit drugs, but the consumption of alcohol and cigarette smoking is prevalent as well. So while we're reviewing that perinatal and prenatal history and neonatal history, we want to take some time to recognize any potential biases that might be present in the identification process. That could be biases that maybe we bring to the table. It may be biases of other healthcare providers. But looking at the information that we do have, we know consistently studies show that substance use disorders are present in all races and economic classes. So we need to be aware of that and to make sure that that knowledge helps us guide us in our identification. Ideally, during that identification process, we're using a structured and validated questionnaire. So we're not going just based on what we perceive as risk factors as an individual, but an evidence-based process and an evidence-based and structured questionnaire that's asked routinely, prenatally, ideally, so that services can be initiated early. But often we find that we are doing that either in labor and delivery or in the neonatal unit, but it should be a structured questionnaire that we use. SBIRT is one that is commonly referred to. Then we also want to look at the clinical presentation of the neonate, and that's where we get into the physical assessment component, and we'll spend a fair amount of time going through that in a more detailed manner. We also look at biologic specimens. That's all part of the identification process. And as well as within the history and the interview, the self-report is one of the most reliable parts to identification. In regards to biologic specimens, I think it's important to remember that there are different options that are available for the biologic specimens. There's the maternal urine toxicology screen. Then there's the neonatal urine toxicology screen. There's the neonatal meconium sample. And then there's the neonatal cord tissue sample. So all of those have their strengths and all of them have their limitations. One of the important things to remember is that the biologic specimen is just one part of the overall process of identification. Each specimen has the risk of having a false negative. And so, because it might be in relationship to when the specimen is obtained and to where the drug was consumed, it may have a false negative. There's also the potential for a false positive, either in the tracking process of the specimen, mislabeling, or there's been some reports as well of with the meconium, if it's left too long, that there could be maybe it's like a fermentation process and you could get a false positive for alcohol. So we want to make sure that we know that the specimen is just one part of the entire process, but it's a combination of all of these above that are the best in identifying the neonate with potential prenatal or perinatal exposure. So we've done a really good review. And we've gone and we've got it. We've obtained the prenatal records. We reviewed them thoroughly. We've talked with the family. And now we're going to actually have the ability to observe and do a physical exam on the baby. So we want to keep in mind basic safety measures and the basic processes of any newborn exam, and that's to keep the baby warm during the exam. Give ourselves time to observe. So often we feel like we need to get there, get moving, jump to it, grab our stethoscope, listen, do our stuff right away. But really just take the time to observe that baby. Look at him. There's so much that you can see in observation. Is the baby comfortable? Is he irritable? Is she sleeping quietly? Is she sucking on her fingers? What is she doing? Take that time, breathing, color, all of that. And during the exam, be careful to be thoughtful, calm, and handle the baby gently. While you're observing, and you're observing head to toe as well as overall movements and activity of the baby, you're also looking for that general morphology. Is there anything there that stands out that could be a sign of a potential teratogenic impact from early exposure to substance? And the most common with that would be fetal alcohol syndrome, secondary to alcohol exposure early in gestation or throughout gestation. That's typically referred to as fetal alcohol syndrome when it's all the components of exposure, such as low set ears, railroad track ears, thin philtrum, and intrauterine growth restriction, those types of findings. Fetal alcohol spectrum disorders are much more difficult to identify in the neonatal period and tend to show up more during development of the baby and toddler and in school age. So one of the things that we're looking at really specifically in relationship to assessment of the newborn is whether or not this baby is experiencing withdrawal. And you notice how we use the term withdrawal and we don't talk about addiction, because babies aren't born addicted. And addiction implies a drug seeking or substance seeking behavior. And that's not what's happening here. The baby is experiencing an abrupt discontinuation of a substance. And that in this situation is typically an illicit substance that we're talking about, or opioids can cause the most significant withdrawal. And so that withdrawal and the impact of how severe that withdrawal is impacted by the type of substance that the newborn was exposed to, the duration of the exposure, and the amount of the exposure. So duration over a period of time, the amount that was consumed in any given time, as well as the gestational age of the newborn. And so what we know is that opioids can cause one of the most significant withdrawals, and opioids consumed over a long duration of time, a higher dosage, and then the baby being term, all of those combined lead towards the newborn showing the most significant signs of withdrawal. And so a preterm baby with less exposure will probably show, or typically would show, less signs of withdrawal because they haven't had as much exposure over a long period of time, as well as they may not be able to mount that response, that withdrawal response, because they're just not as mature and able to do that. So what causes the withdrawal, like we talked about, it's an abrupt discontinuation of a substance. And so in regards to the opioids, we have decreased binding at the opioid receptors in the central nervous system and the GI tract primarily. Those are where we see the biggest signs and symptoms of withdrawal. We have an increase in noradrenaline, and that impacts the autonomic system. So as we go through the different signs or the different presentations of withdrawal, a lot of it is related to that autonomic system. Now you'll hear terminology used both NAS, which is neonatal abstinence syndrome, or NOWS, which is neonatal opioid withdrawal syndrome. And it used to be that we referred to all withdrawal as NAS, neonatal abstinence syndrome. But currently, what we're typically using that for is when we're looking at a polysubstance exposure or a single substance withdrawal other than an opioid. If we think it's a pure opioid that the newborn's withdrawing from, then we're tending to use the terminology of NOWS, which is neonatal opioid withdrawal syndrome. A little different over the last few years with the NOWS coming into play more as a term that we're using. So even though we have the different terms that we're using, both of them may include similar presentation. And that could be irritability, tremors, jitteriness. They're just uncomfortable in their skin. I know that you've seen these babies, and that's probably why you're here, because it's frustrating to see them, and you want to know how to provide the best care for them. So they're those babies, like they just can't quite get comfortable, right? They're irritable in their skin. They may have jerking behavior, jerking of the limbs and such. Difficult for them to really rest and get into a good sleeping pattern. So they'll have poor sleep patterns, irritable crying, and that high-pitched cry that you can just tell that they're uncomfortable. Their feeding behavior could be disorganized. They could be poor feeders, or they could have what we refer to as hyperphagia, which is like, I just want to eat all the time. Like they're constantly gnawing on their hands, they're sucking, they want to eat all the time, and they'll eat even more than they can handle, which then leads to either the diarrhea or emesis with that. So they want to eat, but they can't process it all. So then they eat too much and they have that increased metabolic rate, and so they have diarrhea. Then they get skin excoriation around their anus, and it just becomes a real, it worsens their discomfort. It makes it even worse because they can't console themselves. So we want to use all of this knowledge as we're looking at the baby in that observation process. And this is a nice little table that just kind of provides us some guidance as we're looking at the baby, because we always we want to try to have a system in our mind so that we don't miss something. And that's the importance. That's why it's helpful to have, you're going to do your perinatal history. You're going to do observation, and then you're going to move on to palpation, auscultation, and then palpation. So you have this process in mind. So first, as you're observing, you're just looking at them overall, distress, pain, and discomfort. You're observing their facial expression, their skin color. Are they breathing fast? What is their tone? All of those can be signs of withdrawal. And of course, I'm focusing on withdrawal right now because that's the topic of this presentation. But you also want to be thinking, are there other things that could be causing this behavior in the baby? Because we never want to get stuck with tunnel vision. So that whole time you're also thinking, well, was there anything in the perinatal history that leads me to think that this baby could have an infection? Or maybe they have a low calcium level or something else, low blood sugar, something else that could cause them to be irritable and such. So that's all kind of going on in your head at the same time as you're observing for these signs of withdrawal, because we don't want to miss another diagnosis with that. So we started out, we're looking at the discomfort, color, essentially pink versus cyanotic. Really not a lot and related to withdrawal that would cause cyanosis per se, unless there's true apnea, which is very rare in withdrawal, but it could occur. Is there jaundice, pallor, mottling, meconium staining? The one here that stands out the most that's related to withdrawal is the mottling. We know with the impact on the autonomic nervous system that we can have mottling in the baby with that irritability with them. Nutrition, hydration. Are they able to eat enough and keep that food down, not just eat, but keep it in to have good nutrition? And how's their skin turgor? Or are they from an environment where they're not able to do that? Maybe they had intrauterine growth restriction. And so they're trying to do some catch up growth postnatally. The gestational age, like we talked about earlier, farther along in gestation, higher chance of them showing more significant withdrawal. The neurologic status, is this a baby that can easily move from sleep to quiet awake to alert and ready to eat? Probably not if they're experiencing withdrawal, right? These are the babies that are asleep and then wide awake, ready to eat, crying, irritable, and like there's that rapid state transition that they have. That's what's much more consistent with the baby with withdrawal. They may have tachypnea and increased work of breathing just from their irritability, but you want to make sure that there isn't any underlying lung disease there as well. So you're keeping that in mind. Tachycardia, again, from the irritability, the increased metabolic rate. But you also want to make sure, do they have a high temperature? Is there something else that could be causing that tachycardia? You want to look at that. The abdomen, if they're eating a lot, taking it in, gulping, they may have a full abdomen. They may be gaseous. They might be uncomfortable. So you have to you keep that in mind, looking at that as you're following their feeding patterns. Thrush, do they get thrush from the bottle, taking a bottle if they're taking a bottle? Maybe, maybe not. And then their skin, again, their color, but it's the excoriation, rubbing their elbows, their knees, their hands against their face, sucking, things like that because of the discomfort of the withdrawal. And then overall, their extremities, their tone, they're typically, if they're in withdrawal, they're hypertonic with that. So these are all, this is a good guideline to look at and as you're assessing the baby for withdrawal. So even though a diagnosis is anticipated, we talked about this, it's important to go through all the different steps of the withdrawal, of the physical exam, excuse me. So now we're moving on. Oh, sorry, we're going to do auscultation. So with auscultation, you want to listen to the rate, rhythm, regularity. There's a small percentage of babies that are, if exposed to alcohol earlier in gestation, that can develop congenital heart defects, such as ventricular septal or atrial septal defects. So you may or may not hear a murmur. Those may not even present until a few days after birth, but you are listening to that. Lung sounds, listening to the breath sounds, trying to listen to those and ignore the heart sounds while you're listening, but listening to the heart sounds as well. And then the abdomen. Remember we talked about how the abdomen may be full and gaseous. They may have hyperactive bowel sounds. So you're doing these systematic reviews, but again, as you can tell by the amount of time that I spent on it, observation's key. Observation is really key in this physical assessment. And then we're moving on to palpation. You do your pulses, and do the pulses first because it's easier to get the pulses if the baby maybe is relaxed, if you still haven't relaxed during this time. Then you follow with the abdomen and the kidneys because it's really hard to assess and palpate on a baby that's crying, bringing their knees to their chest. And you're going to palpate and probably just make them throw up if that's the situation. So you want to be really careful again while you're trying to keep the baby calm during this whole process. So this is all of the observation that we're doing in general, just with our general physical assessment. But in relationship to withdrawal, we know that there are some really good structured observation tools that are available. The biggest one was created by Loretta Finnegan back in 1971, and it was the neonatal abstinence scoring system. And that was the first time that there really was a somewhat objective scoring tool put together where you look at all those things we talked about, put numbers related to them, and then add it up. And if it was at a certain level of the number, then you may consider pharmacologic support for the baby. However, um, over the years, there have been a lot of attempts to try to streamline this process, make it quicker, shorter. And so there's a lot of different validated tools out there that do a similar service as the Finnegan scale, but they have different names and just slightly modified. So you may use one of those variations in your practice. Then more recently, we've come up with not we, but a functional assessment tool has been developed. And that's from Grossman and such. And when they created this tool, they thought, we talk about the need for non-pharmacologic support, but our previous observation tools really didn't maximize the non-pharmacologic support in assessing the newborn with withdrawal. So they came up with this functional assessment tool. And what this does is, yes, we're still doing the physical exam on our babies, like we talked about here today. And we're still doing that head to toe assessment with observation and everything. But we're also looking at these functional abilities of the baby, and we're seeing, can they manage these activities that we expect of them as a newborn? How are they managing these while they're experiencing withdrawal? So, how good are they breastfeeding? Are they able to breastfeed as we would expect? Or can they take at least an ounce from a bottle? Are they sleeping for about an hour undisturbed? And if they're crying, can we console them with non pharmacologic support? So, looking at this in a functional manner over the last several years has shown great progress or promise in decreasing the length of stay in the hospital and decreasing the amount of pharmacologic support that we're needing to provide for the babies. So, um, we are able to transition more from a periodic use of pharmacologic support as opposed to a structured round the clock use with a very slow wean like we did for years. So we've had some progress with this. So that was a little bit about assessing and looking at the newborn, how we do our overall physical assessment, the ability to do an observation with a validated scoring tool, and then with the functional assessment tool. Now I want to talk about another very important component of working with families and within the healthcare team, and that is on communication. And communication is a challenge all the time for us. And sometimes I feel like we maybe don't spend enough time talking about the optimal approaches to communication. So, a couple of things we want to think about is your audience. Who are you talking to? And then your approach. How are you approaching your audience? And then what are your own thoughts and feelings as you're going into any sort of communication? So, your audience, in this situation, we're working with families that are experiencing a substance use disorder. All right. And we know, based on a lot of different studies, that there's an associated stigma. And typically, these families and moms in particular experience guilt. They may have a significant history of trauma. And there may also be some cultural norms that are coming into play with our audience. So we want to be aware of what our audience may be experiencing. So what are they living through? Keeping that in mind, we're such great advocates for the newborn that it's hard for us sometimes to separate that out and to think about where they're coming from. So it's really important to take that time to realize the guilt and stigma that they're probably feeling. We also know that the birth of a child is a huge motivator for change. And multiple studies have shown that an interaction, just even one interaction with the caring healthcare provider can make a difference and decrease or make a huge change in the amount of substances that are used or seeking treatment. So we have the potential to have an impact there. So so we talked about our audience, but what are we bringing to the table? What is your view on substance use disorders? What is my view? Do I view that it's a moral weakness? Like they should just say no and just stop? Or is this a true diagnosis? And is this a true medical condition? And substance use disorders are a true diagnosis and it is a true condition. And so trying to keep that to our forefront. What is our personal experience with individuals, friends, family, yourself with a substance use disorder? Typically, we have a story and a story that we're bringing to the table with that. I know that I have a personal story where I had a very favored nephew who, unbeknownst to us and his family, had a substance use disorder, and he passed away from an unintentional opioid overdose. So I bring that with me and that compassion and knowing the impact that that substance use disorder had on the family. And then what is your experience of working with babies in the past and babies with substance use disorders? Did you have positive outcomes, negative outcomes? I know we had a situation once, gosh, it's probably been, well, it's been many years ago when the methamphetamine use was at almost epidemic proportions. And we had a mom and she had a substance use disorder and we didn't recognize it to the degree that it was. And lo and behold, we ended up discharging that baby home without enough support systems in place. And I saw that baby on the front page of the paper and being held by police officers. And he was found in a home that had been used as a meth lab. And he was in his diapers, these police officers and all this protective gear. And so that was a huge moment, like, wow, we failed that family. We didn't make sure they had the supports that they needed. And that baby didn't go home to a safe environment. So making sure that we have all of that, that we know that and we know what we're bringing with us. So when you do meet with a family, what is your approach? Can you take the time to develop a rapport with them, have that welcoming ritual, whatever that might be? Hi, I'm Carol, I'm your nurse practitioner. I'm going to be working with you and your family today. That type of thing. First impressions, eye contact. Can you sit down with them? Use their first names, if you know their first names. Ask about family members in the room. Who should we be aware of? And try to get the names and find out who their support persons are. Then a key component too is using person first language. Now, person first language is always putting the person first. So this is a family with a substance use disorder. This is a baby that's experiencing withdrawal. This isn't the NAS baby in Bay 4, or this isn't the addict down the hall. So we want to talk about them in person first and making sure that we use that. It's a really challenging change for some people to try to do person first, but it's really affirming for families and when we do that. And this really goes for anything, during rounds. Families love it when you use their baby's first name instead of saying he's a 28-weeker with BPD, right? But using names, person first, it's key. And talking with families rather than talking at them. And this concept of communication, it really applies both in the written and verbal. We want to make sure that when we're documenting in the chart, we're using the same therapeutic communication techniques as well. So a case example, I thought I would round this off with a case example, and I've shared this before, but this is a situation where as a nurse practitioner, neonatal nurse practitioner, I was asked to talk to a mom in labor and delivery. And it was one of those situations there's like, oh, Carol's on, she can go talk to the family. She likes this stuff, right? So, but this was a mom who had missed multiple attempts to have a prenatal consult about what to expect in the nursery. She was a mom with a history of a substance use disorder, but she was in medication assisted treatment. So, uh, she we wanted to be able to talk with her, to be able to talk with her about what to expect with her baby and in relationship to withdrawal. However, she missed those appointments with us. So I walked into labor and delivery into her room, and she was, the room was fairly dark, and she was laying in the bed and kind of curled up, looking away from me, and didn't really want to make eye contact. So I sat down and I said, "Hi, I said her name. I'm Carol. It's nice to meet you, and I'm your nurse practitioner, and I want to spend some time to talk with you." And not a lot of response. But then I said, "I see you've been in a medication assisted treatment program for your newborn, and I just want to congratulate you, because that's really one step towards wellness, and congratulations for doing that. I know that that wasn't easy." And then she kind of looked at me and looked up, and I said, that's huge, and you should feel good about doing that." And I said, and then I went on to talk about how, even with that, and that being the best for you and for your baby, there's a, really good chance your baby will experience some withdrawal. And one of the best things that we can do for that withdrawal is to have you present, to help with your baby, to be present, to care for, and do skin to skin contact, provide the feeds, be present as much as possible. And by the end of that discussion, she was engaged and she was talking with me. But I knew that even though she had taken those steps towards wellness, she brought with her that shame, guilt, and stigma of having had a substance use disorder. But it turned out that she did have a baby. The baby did experience withdrawal. She was present for the baby, because she was on a medication assisted treatment and was compliant in that. We encouraged breastfeeding. She was able to breastfeed. Baby went home, and they were very successful. So this is just an example of taking all of those communication tools and bringing them to the patient in a positive manner. So now we have some time for some questions, and Kathy's going to talk to you a little bit more about some of the concepts that I've talked about and how they are in our new book.
So thank you, Carol. I think both Carol and I were very humbled to take over editor of this book. Ellen Tappero and Mary Ellen Honeyfield put this together over 30 years ago because there wasn't anything out there that talked about how to really assess a newborn. And part of this is really, our goal is to focus on the well newborn in many ways, because Carol and I, we were raised with the idea that to know abnormal, you had to be well familiar with what's normal. So we really tried to focus on what does a normal newborn look like, and what should you expect? And then include things that should cue you to further evaluation or assessment of that newborn. So that's really the focus of this, is how do we approach the assessment of the newborn in a comprehensive manner. You can go to the next slide, Carol. Thank you. So we really want to emphasize what a privilege it is and a responsibility to work with newborns. And I think all of you who have chosen working with newborns as a career recognize what a privilege it is to be there for families in welcoming a new life. And it's also a huge responsibility. And it's very important that we have an early recognition of problems. None of us want to discharge a baby that has an unrecognized problem like a cleft palate or imperfect anus because we didn't do a thorough assessment of the newborn. And some problems, for instance, hip dysplasia, if it's not picked up in the newborn period, can lead to significant problems even later on in life. It's also really important that families and professionals get information about their newborns. And it's really fun to show new families all of the amazing things that their newborn can do. It's also an art and a skill. So it's important that you develop a technique so that your examination is accurate, that it's complete, and that having a consistent approach will prevent you from missing things. So and it takes practice in the beginning. It takes a long time to do a complete assessment of a newborn. But as you get practice and get experience, you can actually do a very complete and accurate physical assessment in a short amount of time. But the key is really consistency. And then really looking at every baby as a diagnostic challenge. And if you spend any time in what we used to have well baby nurseries, we don't really have those anymore. But they used to hate when the NICU nurse had to float to the well baby nursery because we always found something. But there's a lot of pathology in the well baby population, and not all of it means you have to do something, but you just find a lot of really interesting things when you spend time examining newborns. The approach is really important, and Carol talked about this approach of starting with observation. And Florence Nightingale said, if you can't develop a habit of close observation, you might as well just give up now because you're going to miss a lot of things. So that is really important. And the first chapter in the book talks about the approach to physical assessment, including technique and the importance of that practice and experience. You can move forward, Carol. With the 7th edition, there were some things that we really worked on. First, we just wanted to make sure that we updated the information. We address every system in the book, whether cardiac, respiratory, renal. We wanted to make sure we had the most up-to-date information wherever possible. And lots of changes keep happening in prenatal testing. So again, we wanted to make sure that was up to date. And then, as Carol mentioned, we really focused on person-first language. So throughout the book, wherever we could, we tried to make sure that we didn't say the Downs baby or the drug exposed baby. We really tried to use that person-first language. So talking about the baby with the cleft palate. So that's really important. And we tried to make sure that we covered that wherever possible. And then we added a chapter on communicating with parents because I think that's really important. My daughter just gave birth to a healthy baby, fortunately, but I asked her, so when they did the exam, did they show you all the things the baby can do? And she said, we were so out of it, I don't even know. And I thought that was really important to remember that parents don't remember much of what we say, and we have to be prepared to repeat ourselves frequently because they're tired. And they haven't had much sleep and they're overwhelmed with everything. And especially if their baby is in the NICU, they probably remember about 10% of what we say. And I think we also have to just be careful about being casual with our language. And we're so used to how we talk and what we say that we sometimes fail to recognize the impact on parents. And I remember one day in rounds, and in this particular unit, the parents were present during rounds. We encouraged that. And we had a baby who had significant intrauterine growth restrictions. So the baby was quite undergrown. And so we're talking about that. And somebody said, well, he had a really ratty placenta. Well, the mother is sitting there looking horrified. So I said, you are not responsible for the condition of your placenta. And she said, thank you for saying that. I thought I did something wrong to make my placenta not work. And of course, that's not what we meant. But we just forget sometimes what we all knew what we meant by that, but parents don't. And so that being casual about how we speak, sometimes we become careless and we're not always as careful. So we included that chapter on really some important things about communicating with parents and helping them get through difficult times, including sharing bad news with parents. So sometimes, unfortunately, we have to tell parents things that nobody wants to have to tell them and they don't want to hear. So we talked a little bit about that. So I'm excited that that chapter is in the book now. And we can really work on how do we communicate with parents and families. And Carol gave a great example of talking to that mother with compassion and meeting her where she was at. And that makes such a difference. So we're looking forward to taking your questions. So please put them in the chat. And I think we have quite a few already. So we'll spend some time addressing those.
Thank you very much, Kathy and Carol. That was such an excellent and informative presentation. As Kathy just mentioned, we will go ahead and take some time for questions now. Please put any additional questions you have into the Q&A box on your control panel. So the first question is around marijuana, and it's kind of a couple things. So Maria asked, do you see withdrawal in infants with exposure to marijuana? If the baby's urine is positive for THC, what guideline is there for safe breastfeeding? And what is the current AAP guidelines? And if the answer is pump and dump, for how long?
A great question. So let's see if I can remember all the components to it. But there isn't in regards to the withdrawal and exposure to marijuana, there hasn't really been a defined withdrawal syndrome related to marijuana exposure. However, there's a lot of case reports related to the baby being more irritable and less likely to establish a sound sleeping pattern. But it hasn't really been validated that there's a specific withdrawal syndrome related to that. Then moving on to the breastfeeding and the use of milk with potential for marijuana being in that, there's a few concepts that I'd like to share and that are used in making that decision. And first is that one, we absolutely know that marijuana, the THC, the psychoactive component of marijuana, does cross from the mom in the bloodstream into the breast milk. It crosses into the breast milk, and that THC is what we call lipophilic, so very fat loving. And we know there's all that great fat in the breast milk. That's why we like breast milk, all those great fats in there. But it's fat loving, and because of that, it's fat loving, it adheres to that. And we also know that THC has a very long half-life. Studies have shown that it can be present up to 6 weeks after consumption. So, of course, there's a peak and a fall off. So the concepts are, one, the THC, the psychoactive component, absolutely crosses into the breast milk. Two, it stays there for a long time. So that really doesn't lend towards a pump and dump type of a process, unless you're going to do that for, weeks, if you will. On the flip side, I will say, though, that there are so many wonderful components to breastfeeding that there's often a discussion, and there needs to be a discussion, especially on the term newborn, about what's the best for that baby. And what the AAP recommends and what NAN recommends is that you have that discussion with the family, and you provide this information, this education to them, and you encourage them to abstain or to really decrease their consumption. So you really encourage that. You share the information, you encourage them not to use during breastfeeding, but you continue to provide them with the support and the lactation support, so that should they choose to breastfeed, that they're providing, good milk, as opposed to losing their milk supply, if you will. So it's a very complex question with that, but the bottom line is educate families on the risk, assume that they want what's best for their baby, and then encourage abstinence or really decreasing their use as much as possible. Then if we go into the sick newborn, into the NICU, it's a whole nother discussion because the healthcare providers there are actually writing those orders. And so you have to have that discussion as well and take into account the preterm brain, developing brain of the preterm infant and such. So it could be a more complex question and answer.
And Carol, if I can ask a quick follow-up, Sandra said in the chat, if it is decided breastfeeding isn't right for the mom, would they be offered donor milk?
They absolutely could be offered donor milk, and if it's available, they should be offered donor milk. I know different hospitals have different policies on which babies are eligible for donor milk and how it's used, but absolutely they could be a candidate for donor milk.
Awesome. So the next question is from Doughton, and that is, suppose we don't have any information on antenatal exposure. Are there any signs that can strongly indicate in that direction? Signs that are relatively specific to the antenatal drugs exposure more than others?
So another good question. And I think really that's where when you have that baby that is showing those signs of withdrawal, that's when, if you have an irritable baby, a tachypnic baby, a baby that's hypertonic, and you might be evaluating for hypoglycemia or infection, respiratory distress, then we should have neonatal withdrawal up there within our differential diagnosis to look at as well. And so just like I talked about how you don't want to get down that narrow tunnel vision of assuming all these behaviors are withdrawal. You also don't want just to assume just because you don't have that history of withdrawal, you don't want to assume that it's not withdrawal. And so you want to look at the whole big picture and know that this could be withdrawal and to keep it on your differential diagnosis. And I think it's the clinical presentation of the newborn that is the biggest thing that we would see, and that would bring that to the forefront.
Excellent. The next question was from Anonymous, which is, I love that you use therapeutic communication with families. We know families have access to their medical records immediately after a provider documents. The language for documentation is extremely different from therapeutic. What is your suggestion for language consistency that will support the family?
Yeah, that's a great, another such good questions, you guys. Yeah. Thank you for being here and asking these great questions. I think where we're limited is when we're using like ICD-9 codes and such. Those may or may not be as therapeutic as we wanted when we're entering those exact diagnoses, if you will. But any objective or subjective data that we enter into the medical record can be written in person first language and a therapeutic manner. It's just a matter of changing your mindset and doing it that way. You can write the same things that you speak. And so you still can do that. And I think it's really important because especially, if we're the first person to encounter this family and we can help set the stage, if you will, for how communication is managed with our community partners and such as well. So we really do have an opportunity to set the stage with that communication, both in the written form and in the spoken word.
Excellent. Oh,
I would add
did you
to
want to
that.
add, please?
I think this illustrates the importance of having nurses involved in knowing about informatics and having nurses involved in creating the electronic health record, because some of the drop-down choices we're given are not very therapeutic. So I would just encourage us to be be in those discussions when those electronic medical records are created. Because, and the more we educate providers and educate the people who are creating these, this technology, the better those choices will get.
Oh, that's great, Kathy. Thank you for pointing that out as well. Good point.
And just as, since I'm with Springer, I wanted to add that we have multiple titles on informatics. So if people are interested in learning more about our nursing informatics titles, you can come to our website and find those. We have time for just a couple more questions. The next question was, would you use the Finnegan or an ESC tool to assess a neonate with THC exposure, only marijuana was consumed?
You know, I'll answer this, but with the caveat that I don't know of any good studies to say that one would be better than the other. But personally, I think that the Eat, Sleep, Console is more applicable in that situation, because since the baby with exposure to marijuana doesn't have that specific withdrawal syndrome that we're aware of, what we're really looking at is how is this baby eating, sleeping, and being able to be consoled? How is this baby managing and functioning his activities or her activities of, you will, of daily living? So I think that that's the Eat, Sleep, Console is a better tool in that situation. You may not need any tool at all. The baby may do just fine and not have any signs of withdrawal.
Excellent. And the next question is, are you able to provide a resource that THC stays in the system for up to 6 weeks?
It was in the, it was detected in the breast milk in small amounts up to 6 weeks. And that was a study out of California that came out about 3 years ago, I think now. And I can't remember the exact title off the top of my head, but I can get that to you.
Excellent. And we can certainly follow up when we follow up with everybody after the webinar. Another question just came in that is back to the THC and breastfeeding. Would the mother pump to keep milk availability until the THC was out of her system, and in the meantime use donor or formula?
That's a very common practice, yes. Very often, and the thing with that, I mean, gosh, that really shows a huge commitment on this mom to be able to pump and not be able to use her breast milk at that time. But if the decision is that the breast milk is not to be used, and that should be a decision, that's made in conjunction with the family and the healthcare team, then absolutely you can have her pump for a period of time until at least the majority of the THC is out of the milk, or that it's a reasonable amount of time that it would be out. Again, the data is limited on this, and the up to 6 weeks, I just want to emphasize that's a small amount, a residual amount that's left there. And it really just demonstrates the long half-life of the marijuana. So we can't really apply the pump and dump that a lot of times people will do, whether or not we should, but is used around consuming alcohol and breastfeeding because it has a shorter half-life. That really doesn't apply in this situation because the half-life is that much longer. But yeah, pumping for a period of time, there's not a perfect time that's out there that's studied that we can say it'll all be gone at this time, because each person is different, again, in their metabolism, the amount they've consumed, how long they've consumed. Those are all variables that play into how long that THC is going to stay in the milk.
Excellent. Well, we're pretty much up on the hour, and I just want to thank everyone for spending time with us today, and thank you again to Carol and Kathy for a great presentation. As you can see here, if you're interested in purchasing Carol and Kathy's book, Tappero and Honeyfield's Physical Assessment of the Newborn, you can receive a 25% discount using the code webinar24 at checkout on springerpub.com. And we'll also include this information in our follow-up to everybody. So, and if you can go to the next slide, please, Carol. I just wanted to mention this recorded session will be available on Springer Pub within 5 to 7 business days. Thank you again, Carol and Kathy. Thank you all for all your questions and for all of you that attended from all across the country. We were thrilled to have you here today. We want to wish everyone a great afternoon, and we look forward to you joining us for future Springer Publishing webinars. Have a great day. Thanks.
Thank you, everybody.
Yes, thank you for being here.